The next topic is next topic is a revision of intracranial aneurysm treatment. What new regarding coiling and flow diversion? Professor Laurent Pierrot, please, Steph.
So good morning, everybody. I am very happy to participate to the Vietnamese Society of Radiology meeting, and thank you to Professor Phan Minh Tong and Professor Vu Dong Lu for the very kind invitation. So I will now discuss revisiting intracranial aneurysm treatment, what's new regarding coiling and flow diversion. So my topics are, I will discuss coiling, I will present you optimal coils, and I will show you the preliminary results of instant study. I will also show you flow diversion and what we can do with the Silk Vista and Silk Vista baby flow diverter from BALT. And I will show you some clinical experience we have with this flow diverter. So coiling, optimal coils, instant study. So what is the current place of coiling in the aneurysm treatment? So I show you here the results of ARETA study conducted in France regarding the modalities of endovascular treatment according to aneurysm status. You see that for ruptured aneurysm, coiling alone or balloon-assisted coiling was used for ruptured aneurysm in 98% of cases, which is not a surprise. For a ruptured aneurysm, the rate was lower because we are also using web flow diverter on stent-assisted coiling, but you see that the coiling is still 73% of cases for unruptured aneurysm, and in global, the rate of coiling is 88% of aneurysm. So coiling is still the first-line treatment for intracranial aneurysm. So what is the Optima coil system from BALT? The Optima, it's an optimal design with a novel hypotube pusher offering best-in-class distal softness for precise deliverability and control. And really, we in our department is our first-line coil, and let's say that we exclusively or mostly use this coil, and it's a very good coil. So detachment is in an instant with thermal detachment. It means that you press the button and the coil is detached. Implant with optimized softness profile and increase size offering, which is good. You have a lot of sizes, so you can really select your coil for the treatment of intracranial aneurysm. I show you some example here. Ruptured decom, you see the bleeding here, you see the aneurysm here, you see the placement of the coil, you see the aneurysm here, you see the placement of the coil in the aneurysm, 5 optimal coils. It is a final control angiogram, and it is a 12 months control angiogram showing complete aneurysm occlusion. Here, another example, ruptured MCA treated by clipping. You see the clipping, the clip is here, and the surgical way is here. So you see that we have a control angiogram after the treatment, and we have an aneurysm remnant. So we were deciding to treat this remnant with coils. So we were using at the beginning a non-optimal coil, a coil from another company, and it was not possible to place the coil in the aneurysm sac. You know precisely that it's difficult to treat a clipped aneurysm because the clip is very rigid, and the coil is pushed outside the aneurysm sac. So we were using an optimal coil. We were able to place an optimal coil, and it's a final result showing complete aneurysm occlusion, and it's a 12 months control angiogram showing complete aneurysm occlusion. Instant study, what is it? I am the PI. The sponsor is BALT, indeed. The device used in this study is the Optima coil system. The study design is a non-interventional, prospective, single-arm, international, multi-center study. The sample size is 300 patients, and it was conducted in 7 countries with 19 centers active in Europe. The objective was to evaluate the morbidity and mortality, global indeed, related to the Optima coil system at 30 days and 12 months post-procedure, to evaluate also the occlusion rate at 12 months, and to evaluate some technical features specifically for the detachment system of the Optima coils. There are some committees. The core lab, there is an independent core lab who is Professor Phil White from Edinburgh in UK, and there is a clinical event committee with Professor Denis Abreteau in Tours, France, and Dr. Anne-Christine Janelle in Toulouse, France. So we have conducted an interim analysis. So recruitment is completed, but not all follow-up are available. So we were conducting an interim analysis with 150 patients having completed the 12 months follow-up. We were evaluating safety and efficacy according to the investigator assessment. So it is a flow chart. I have no time to discuss the flow chart. The population is, the mean age is 55. As usual, more females than male. You see that the rate of hypertension, elevated blood pressure is 40%. Smoking active is encountered in 38% of cases. Most aneurysms were unruptured, 55% of cases, and 44 were ruptured. Most aneurysms were small, at 92%, and location were ECOM first, 44% of cases, ICA supraclinoid, 30% of cases, MCA, 16% of cases, vertebrobasilar aneurysm, 6%, and finally, ICA intracavernous, 3%. So, when we look at mortality at 30 days, you see that there was no mortality, 0% mortality. There was morbidity in 11%, but it was related to subarachnoid hemorrhage in most cases, 10%. It was related to procedure rebleeding during preoperative DSA. It means before placement of coils in 0.7% of cases, and related to another disease, lung cancer, in 0.7% of cases. So indeed, morbidity was mostly encountered in ruptured aneurysm, 24% of cases, mostly due to subarachnoid hemorrhage. And in unruptured aneurysm, you see that the morbidity is very low, 1.2%. Now, when we look at anatomical results, postoperatively in unruptured aneurysm, you have complete occlusion in 78% of cases, and in ruptured aneurysm in 87% of cases. At 12 months, we have complete occlusion in 79% of cases, and in unruptured aneurysm, and in 60% of cases in ruptured aneurysm. Don't forget that it is self-evaluation of the centers and not core lab evaluation. So we will check in the future indeed the results of the core lab evaluation. Flow diversion, Silk Vista. So what are the current indications for flow diversion? Due to its high efficacy, flow diversion is increasingly used in the endovascular treatment management of intracranial aneurysm. Initial indication in Europe were large and giant ICA aneurysm and recanalized aneurysm. With the development of new flow diverters, singularly the Silk Vista, we have a progressive enlargement of indication to small ICA aneurysm, distal aneurysm, bifurcation aneurysm. The use of FD remains controversial in the treatment of aneurysm located in the posterior circulation, and to some extent, the use of flow diversion in bifurcation is also still a little bit controversial, but I have to say that we use a lot of flow diverter in the bifurcation aneurysm. So, an overview of the silk development. The silk was introduced in 2008. In 2012, we had the silk plus. In 2018, we had the silk Vista baby, and in 2020, the silk Vista. So there was a diversion study. There was an analysis of the result of silk treatment in diversion study, which is a large study conducted in France, analyzing all flow diversion treatments, whatever the flow diverters used. So we were conducting a silk subgroup analysis was conducted. You see that the treatment took place between October 2012 and February 2014. There were a little bit more than 100 patients. You see that mortality was 2.9%, morbidity 26.5%, and aneurysm occlusion was complete aneurysm occlusion at 1 year in 64% of cases, and adequate occlusion in 82% of cases. Silk Vista and Silk Vista baby, you see that it's 48 braided wires mesh-like design. Silk Vista and Silk Vista baby are made of DFT wires, so 19 with platinum inside, which give full visibility of the flow diverter, as you see here. It has a homogeneous mesh surface, which make the stent opening very smooth, and it has radial resistive force, which make an increasing compression stent force, with which lead to good wall apposition. And finally, we have the high stent conformability, which make it very navigable. You see that here it is very conformable to a very tortuous vessel. Silk Vista baby, we have several diameter, 2.25, 2.5, 2.75, 3, 3.25. It is the first and only flow diverter deliverable through the 17 microcatheter. The Silk Vista, 3.5, 3.65, 4, 4.25, 4.5, 4.75, and it is deliverable through the 21 microcatheter. Just to show you some example, here, an aneurysm, IC aneurysm, posterior communicating aneurysm. The strategy was decided to be flow diversion and coiling. So we were placing coil, but we were not able to deploy a flow diverter, which was not at the time of this treatment, the silk. So we were just placing coils, and we were coming back in October 2021 with this recanalization, and now we were able to place a Silk Vista 4.75 by 20, and it is the end of the procedure, and you see that the stent is perfectly open and perfectly applied against the arterial wall. Here another example, unruptured ECOM. You see that the width is 11, the height is 8.9, it's a relatively large aneurysm. We treat the aneurysm with a Silk Vista baby, 2.75 by 10. And you see here, we have also a microcatheter in the aneurysm sac to place coils. You see it's a vasosity after deployment of the web. And after that, we will place some coils on the final control of the web is complete aneurysm occlusion. Here another example, MC aneurysm with a very wide neck. You see that one branch is more or less coming from the neck, this one. So what we do here, we will place a flow diverter here. So we use a silk plus 3 by 15, and it is the final result. You see that the postoperative DSA show a good placement of the stent without any stenosis in the stent, and it's a 6-month DSA showing complete aneurysm occlusion. Here, it's a superior cerebellar aneurysm with a wide neck treated with coils in March 2015, recanalization in May 2016, treated with web, recanalization in January 2021, treated with a Silk Vista Baby 3.25 by 15, placed in the left P1 and basilar artery. You see the Silk Vista Baby here, and it's a final control angiogram, and it's a control angiogram 6 months later showing complete aneurysm occlusion. Here another example, ACOM aneurysm treated with coils in 2015, recan in 2021, treatment with a Silk Vista Baby 2.25 by 15 with and coils, and it is a final control angiogram showing a very good opening of the flow diverter with good apposition on the arterial wall of the complete aneurysm occlusion, and DSA at 6 months show a complete aneurysm occlusion. Here, another example, ruptured MCA treated in January 2012 by clipping, and it's in March 2022, we see that we have a recanalization. The treatment is decided for endovascular treatment. So what we do, we place the flow diverter. Again, you see that we are able to precisely place the flow diverter in front of the neck. The flow diverter is completely visible, the vasosity, and it is, we place optimal coils in the aneurysm remnant, and it is the final control angiogram with complete aneurysm occlusion. In conclusion, optimal coils has a very good instantaneous detachment. They are associated with a great safety. Silk Vista and Silk Vista Baby are fully visible. They are delivered through the small microcatheters, 17 for Vista Baby and 21 for Vista, permit enlargement of indication to distal and bifurcation aneurysm. Thank you for your attention.